Good afternoon, everyone, and thank you for joining us. This is Paige Hancock, Marketing Manager at Spok, and I'll be moderating today's webinar. Today, we'll be talking about how health IT can extinguish physician and nurse burnout. Dr. Natay Guyton, Chief Nursing Officer, and Dr. Andrew Mellon, Chief Medical Officer at Spok, will share their insights and industry research on burnout in healthcare today and how technology can help your physicians and nurses love their jobs again. Before we get started, I would like to go over just a few housekeeping items. Everyone will be muted during today's webinar, but we do welcome your participation. Please submit your questions via the questions box, which is in your GoToWebinar toolbar, and then Natay and Andrew will answer as many questions as time allows after the presentation. A recording of this webinar and the presentation slides will be sent to all registrants tomorrow, and please do feel free to share these with others at your organization. And lastly, at the end of the webinar, you'll have the opportunity to complete an evaluation. We would love it if you could take a couple of minutes to complete this quick survey. Your feedback really helps our efforts to provide you with relevant and informative presentations. And with that, I'd like to turn it over to Natay, who will begin today's presentation.
Thank you so much. Good afternoon, everyone. And first, I would be remiss if I didn't say Happy National Health IT Week. So we wanted to dedicate this webinar to all the healthcare and IT professionals out there because we know that you are impacted by technology every day, everywhere around you in a hospital setting, also in your personal lives. So we know what you do for our patients, what you do for healthcare, is really demonstrating the value of what Health IT Week is about. So again, happy Health IT Week, and thank you so much for all you do. Our leadership and our staff at Spok recognize you, and again, we say thank you for what you do every day. So today's agenda is very exciting. We're going to be talking about what burnout means for caregivers, hospitals, and patients. We're also going to be talking about technology's role in burnout, right? Because even though it's Health IT Week and we kind of give a great message around how technology has helped us and has, changed our lives and moved us to a whole nother a world, another level, and how we care for our patients. We do know, from a personal and also from a research perspective, that technology has and can lead to burnout. So we'll talk about that. We will also talk about how health IT can help physicians and nurses love their jobs again. And again, this is not just for physicians and nurses, but our IT directors, all our clinical or non-clinical staff in the healthcare arena. So we hope to give you some tidbits around how to love your job again. So here's a nice analogy and research that we found here. And so we know that burnout is more than a buzzword, even though over the years we're starting to hear burnout more from our patients, from our staff, from our clinicians, from physicians. I recently had an opportunity to attend a seminar at the University of Pennsylvania, and they're really focusing on burnout for even students, and they're offering a yoga class for their students in terms of burnout. So it's more than a buzzword. And what we found that over half of doctors surveyed have experienced burnout, and that's an increase of 25% in just 4 years. So I just want to urge you to think about, as I say that, right, 25%, over half of the doctors across the United States. Think about that in terms of how you feel, in terms of how you kind of felt some burnout over the last 4 or 5 years. And think also about, as we go through this webinar today, what has caused that and what can you do personally to alleviate that? So like I said before, kudos to University of Penn, who not only recognize this in physicians who are practicing today, but realize that even going to school, becoming a doctor, being in a clinical setting, seeing the tragedy and the trauma that we see today in our world, and offering a program like yoga or meditation that is helping their students. And it's really giving them a kind of a roadmap of how to deal with burnout. Also, we know that 1/3 of nurses report being burnt out. Now, there's 3.13 million nurses in the United States, and if we say 1/3 of our nurses are reported being burnt out, right? And these are the ones that report it. I mean, can you imagine the ones who haven't? And so when we start to think about the impending doom, if you will, of the nursing shortage that researchers are saying by the year 2020, we will see the largest nursing shortage that we've seen. And think about it in terms of burnout. Oftentimes we think that, nurses are not going to school, the pipeline is not being replenished, but a lot of our veteran and newer nurses are burnt out and leaving their profession. So again, burnout is more than a buzzword. Next slide. So some symptoms of burnout, right? And a Maslow burnout inventory addresses 3 scales. So again, look this up and maybe take that inventory so you can recognize maybe the burnout maybe you feel or your team. So 3 scales: emotional exhaustion, depersonalization, and personal accomplishment. Next slide. The causes of burnout. And again, we see this in ourselves, we see this in our staff. 1, too many bureaucratic tasks, spending too many hours at work. So again, we talk about that work-life balance. And work-life balance, we know, I've been in healthcare for almost 20 years. And so we're open 24 hours a day. We have patients that need to be seen. And so it's always been hard for me to kind of realize that work-life balance. But again, how can we connect with our staff to understand what they're going through? Sometimes the causes of burnout could be they're feeling like just a cog in the wheel. And so this kind of disturbs me because as clinicians, right, or non-clinicians, we got into healthcare as advocates. We entered the profession to be able to do something and make a difference. And oftentimes making a difference or being able to make a change and see that change within our profession, that is something that really helps us to and energize us and help us to see the value in what we do. So when staff say they feel like a cog in the wheel, that kind of disturbs me in the healthcare settings because everyone in the hospital is valuable and have a part to play, whether you're touching patients or not. And then last but not least, which we're going to talk about through our webinar today, causes of burnout: increased computerization of the practice. Now wait a minute, right? So this is a conundrum because we in healthcare technology, as we celebrate Health IT Week, we wanted to implement technology to save time, right? Ultimately save lives, provide better patient care, provide efficiency at the bedside, helping clinicians connect and communicate better. But what we're seeing in our world today and in our work today is a lot of our clinicians or non-clinicians are saying, because of all this computerization, I don't know whether it's the computer on wheels, I don't know whether it's the iPhone and now the watch, and then I have the SpectraLink phone and the utility belt of devices, they're saying, guess what? We're burnt out. So again, as we recognize health IT and all of its values and how we have changed healthcare today, we would be remiss if we didn't look at how IT and some of the computerization of practices have caused burnout in our clinicians. Next slide. So why everyone needs to care about burnout, right? And of course, when you think about your own personal burnout, you think, yeah, sometimes I think, does anybody care that I'm tired, that I'm burnt out? But burnout has been shown to lead to reduced focus, effort, empathy, and bedside manner. And again, as we look at doctors and nurses and radiologists and respiratory therapists, these are our frontline clinicians. And so we're trying to help improve care and improve efficiency and improve coordination of care and communication. But on the flip side, do we want to decrease focus, effort, empathy in a bedside manner? And we also know that all of these points have led to misdiagnosis and medical errors. So the next slide. So today, as we get more into what's the right technology to help you alleviate or diminish or even reduce burnout. This statistic I thought was very telling here, because I often hear clinicians say, you know, I have to spend a lot of time with the technology. I spend a lot of time in front of the computer. I hear nurses all the time say, where's the human touch? So what we found is 1 hour of FaceTime with patients, it can and has equated to 2 additional hours on the EHR and clinical workflow. So in essence, you know, and I'm hoping I'm getting this point across clearly, in essence, what this is saying is, with the technology we have today, we're adding less face time with patients and their clinicians and their nurses, and more time with clinicians interfacing with their computers and their EHRs and technology. So somewhere along the way, the reduction or the efficiency in bringing nurses and physicians back to the bedside have been eroded. So today, our conversation is really kind of to challenge what we're doing today and how we're moving forward and providing care and access and technology for our clinicians, ensuring that we have the patients in mind, the clinicians in mind, and last but not least, ensuring that we're not burning out our frontline staff who are there to be empathetic with our patients to provide the utmost in bedside manner. So I'm going to hand it over to Dr. Mellon, because after I shocked you here, you know, he's going to really take you through some workflows and comment around what is the right technology, what is the best technology that'll help with all of those factors of burnout that I discussed. Dr. Mellon?
Thank you, Natay. So this is Andrew Mellon. I'm Chief Medical Officer here at Spok. It's my pleasure to talk to you all today. Now, I spent some time, even before my time at Spok, thinking and learning a lot about this topic. My father's a physician. Many of my friends are physicians. I worked for 15 years part-time as a hospitalist. And it's really tough to be a physician these days. You know, I feel like a lot of my friends who are still practicing feel trapped being a physician. They want to get out, but because of all the training they put into this and all of the income demands and the income expectations, they have no way out. And so they're all looking for ways to get better, ways to make this better. And there's been lots of studies around what causes physician burnout. And the way I've often heard it described, it's like a death by 1,000 paper cuts. Death by 1,000 paper cuts. Those paper cuts, you know, in some of these surveys are things like too many bureaucratic tasks, spending too much time at work, too much increasing computerization, the impact of all the regulations in the Affordable Care Act that Tate pointed out, being like a cog in the wheel, and many, many other things. So, you know, what I'm going to talk about today, we're not going to fix 1,000 different paper cuts, but we're going to chip away at that. You know, technology is part of, has caused some of these problems, you know, according to some of these surveys, but I want to walk through some workflows and opportunities to use technologies to simply make the physicians' and nurses' job and their care team's job easier. Take away some of those paper cuts that grate on you every single day. So here's the first one, and this one I personally felt very acutely in my role as a hospitalist when I did that. How do you figure out who to get in touch with? How do I know who to get in call, who's on call for a given specialty, how to best get in touch with them, and how to reach them and have a conversation with them. My old workflows used to be sitting there basically either mucking around in some bad directory, which wasn't Spok, trying to find them, or giving up and asking the health unit coordinator or nurse to track them down for me. So this is a pretty common scenario I dealt with. Patients ready to be discharged. We used an EHR. I could be waiting for a lab result and be off the floor. If the result comes back, it looks good, I'm ready to send them home. But I also want to make sure that the cardiologist I'm working with is comfortable with this result. And I also want to make sure the nurse knows that they're ready to go home. Because I know if I just put an order in the EHR, they may not see that for a while. So what happened? So in the old world, I would have probably dialed 0 for the operator, and then I would have asked the operator to connect me to unit 5500, and then I would have gotten the health unit coordinator, and I would say connect me to the nursing care room 5502, and I'd sit on hold, and then I'd get in touch with the nurse, and we'd have a conversation. I'd say things look good, ready to go. And that would be the extent of it. Same thing with the specialist. I would ask the health unit coordinator, page this person. I would wait and wait and wait. And maybe a half hour later, while I'm in the middle of a patient working with another patient, I get a call back. But now with Spok, a lot of that waste, a lot of that frustration, a lot of just that time of bureaucracy of just getting in touch with people goes away. I could look up the specialist on my phone. I would simply say who's on call for cardiology that day. You know, I often work Saturdays, so I wouldn't know. And say on-call cardiologist, hey, okay for this person to go home. They'd write me back. I wouldn't have to wait. I could keep moving on. They'd say, sure, all good. Thanks. Then same thing. I'd have the conversation with the nurse, all asynchronously. There would be no intermediary trying to find this information for me. I'd have it all at my fingertips. So again, take away a few paper cuts, a lot of that wasted time of just, I want to get over with, be done with this task and move on. So again, a small win, but a very important one that happens many, many, many times over the course of the day. Let's look at another area, saving steps. And I think this is a fascinating one around managing critical results. You know, 400 million test radiology results in the US every year, 13 billion lab tests, and a percentage, you know, 5, 10, 15, 20% need to be notified immediately to the caregiver. It may be a critical radiology result that someone has a new pneumothorax, someone who has a potassium of 6.5 in a critical range, and you not only need to make sure it gets sent out in the ether, but you need to make sure that that person acknowledges it, accepts responsibility, and takes action. So how does that happen typically? And so this is a workflow I've talked to a number of radiologists about. So what happens in their world today without any additional help? They see a critical lab result. So in this case, someone ordered a chest x-ray, there's a pneumothorax or air on the outside of the lung. You know, this could be a tension pneumothorax, which is an emergency, something needs to be done. And that internist or hospitalist or pulmonologist, whoever's caring for that patient, absolutely needs to be notified quickly to take action. So in the current world, I've heard radiologists tell me it takes 10 to 20% of their time over the course of the day to track down people to deal with these scenarios. So think about it. You're a radiologist. You go through a lot of training. You get compensated based on looking at films and using your knowledge to make diagnoses and interpret these films in meaningful ways. And yet you're spending 10 to 20% of your time on secretarial or administrative work saying, how can I find this person? How do I make sure I get in touch with them? I don't want to wait on hold. And that's really frustrating. So and it's also a medical liability issue, that if you haven't tracked and managed that and specifically documented that I followed up with that provider who's taken accountability, then I feel like I'm at risk, or I know I'm at risk. It's not the right thing to do, and it doesn't meet the JCO requirement. So in this scenario, with technology's help, when that critical result comes back and the radiologist sees it, the system can automatically interpret that it was a critical result. And it can send the relevant information off to the person who's responsible for that patient. So immediately, without any additional interventions or actions by that radiologist, that result goes off, gets sent to the responsible person. But after a defined time period, if that person hasn't accepted accountability, hasn't specifically acknowledged yet that, yes, I've seen this result and I will own it and take action on it, that will get escalated based on an escalation path. So, and then in this case, go from the intern to the resident. So in this scenario, you've taken all that burden off the radiologist who doesn't want to be a secretary, who doesn't want to be looking up phone numbers, who simply wants to take care of patients, read the film, do procedures, add value to that patient's care process. That entire workflow and process has been eliminated. And in addition, that phone number can come in with that result. So if that person who does receive the result wants to talk to the radiologist for more detail, they can immediately call them back right by clicking on the link. So again, another few paper cuts for that radiologist gone away. Next one, gaining focus. So as a physician, I worry a lot about patients that are deteriorating. I had a colleague tell me the other day that he got a page from a nurse or a message from a nurse that said, patient is coding, your patient is coding, come right away. The problem with that message was there was no patient in the message. So, they didn't know what room, he didn't know what patient. He said, through my deductive powers of knowing who was sick on my list, I was able to kind of figure out who it should be and ran over there. And, meanwhile, the nurse paged me back a few minutes later saying, sorry, I forgot to tell you it was this patient. But, as a physician or as a nurse, you're constantly worried about that. You want to know when your patient's status is changing, and you want to make sure they're being acted on. So one of the interesting workflows that one of our organizations, actually multiple of our organizations have embedded through a communication platform is dealing with critical changes in patient situations and making sure, taking some of that worry away of making sure that the right people get notified and act on this. So, so this was an interesting one. So actually, let me do the old way first. So the old way of doing this is a nurse or a tech or maybe a medical assistant would go into the patient's room, check their vital signs. They would document, that maybe their heart rate's up a little bit, their blood pressure's up a little bit, and then they would move on to the next patient. Then I would come see that patient 3 hours later, and I'd look at the vital signs, and some alarm bells, some would go off in my head saying, this is a change, it doesn't seem right. Then I walk into the patient room, and they're doing really bad. And that is a situation none of us want to be in, especially when we knew that information before. It's hard to explain. It's just wrong for the patient. So what organizations are doing now is hardwiring these processes. So not only are they making sure that the alarm bells are going off when they need to go off, but they are making sure the right people act on that and take intervention immediately. So in this example, let's go back to that same example. The nurse or the nurse tech or the medical assistant goes into the room and takes the vital signs. So, these vital signs are a little bit off. They have a fever. They're breathing a little bit faster than normal. Their heart rate's a little bit higher than normal. But there are algorithms now, one's called MUSE, Modified Early Warning System, that can say, hey, this is a sign that something might be going on and that they need more evaluation. So what happens now is instead of that tech or a medical assistant just putting those numbers in and walking away, an alarm bell goes off. But if no action's taken, it doesn't do any good. So in their EHR, the alarm bell goes off and says, hey, they validate these scores. The tech says yes, and that immediately sends off messages to the rapid response team. So you've hardwired this process. You've taken away a lot of that worry that things are happening and no one's acting on it, and you're getting the information to the right person without any chance of delay, without any chance of error, and with 100% chance that the right people are going to see this information and act on it. So again, it serves as a safety net for physician. It takes away a little bit of my worry and gives us assurances that you'll be focused and you'll be able to the right people will take action on this. So here's another one. Alarm fatigue is a huge problem, especially for the nurses and the techs that sit on the floor all day. They're walking around, lights are going on, off, the telemetry alarms are beeping all the time, and it's just noise. And there's obviously some things that happen where different sounds go off when there's really critical things, but it's all noise that someone has to see and act on. And so alarm fatigue is terrible, and 85 to 99% in studies are not actionable. So what do you do about that? How do you make sure that you can only taking actions on the right one? You're not reacting the same way to every single signal, every single alarm that goes off. And how do you make sure that that alarm only goes to the appropriate people? So if it's an emergency, give it, send it to the nurse, send it to the physician. If it's a non-emergency, maybe it's something the medical assistant or a tech can deal with. So let's walk through an example of that. So someone has a telemetry monitor on them. They have this box that's monitoring their heart rate, and it has a battery in it. So that alarm is going off for various reasons. It goes off when a lead is off. It goes off when a battery is dying. It goes off when the patient's heart rate goes into a fatal arrhythmia, and you better be running into that room really quickly. 3 different scenarios, 3 different sets of urgencies. So how can you deal with that? Instead of all of them beeping and setting off a little light in the nursing station or telemetry area, or hoping someone hears a different sound, what you do is you take that information that's coming to you and you filter it and route it. So you can look at the information that's coming there. Hey, in this situation, it's just a battery. We know you've got about, let's say, 12 hours before that battery dies. No one needs to run into that room. And in fact, the nurse, this isn't even something a nurse or someone with that level of training should ever deal with. You want people working at the highest level of their license. So take away these nuisance alarms, help people operate at their highest level of their license, and get it to the right person. In this place, you can route that alarm to the biomed person, who can go up to the floor, put a new battery in. The nurse would never even know about it. So you've silenced the alarm, it never beeps. You've taken away this non or minimal value add work from someone at who has a high skill level, like a nurse, and you've taken care of the patient, and you've taken care of the action that needs to be done. So quiet hospital, but taking away tasks, burdensome tasks from people that don't need to do that. So this applies to all kinds of different alarms or events, whether it's a telemetry alarm, a ventilator alarm, even things like facility alarms for HVAC or stuff like that. Those can all be interpreted and routed automatically to the right people with the right level of urgency. So taking away a lot of that noise that caregivers deal with, that's just frustrating to them. All right, let's look at that last scenario, something that everyone talks about. Nate talked about, I think, 1 hour of bedside time, 2 hours of computer time for every hour of bedside time. That's a shame. So how do we get time back to that bedside? So part of that is helping people, giving people the information they need. One of the lessons I've heard and requests I've had for many, many years and working in EHRs and helping build them and design them was just show me the information I need. And a lot of times that's really hard in an EHR because you sit down and talk with a cardiologist or orthopedist or an internist. I can't read their minds, and they all want something different. But a lot of times there's context that you can provide with information that allows people to make better decisions. So here's an example. An alarm goes off in a patient room. They push the button that says, "Hey, come to my bed. I need help." Well, when that alarm goes off, 3 things can happen. 1, a light could go off outside the room, and things can beep. Well, you have no information whatsoever, right? And not only that, it's not delivered to the right person to even act on. So that's not good, although that's the way many hospitals still operate. So what's the next step that's a little bit better? Well, you send a beep to someone's phone or a smart device. Button was pushed in alarm in bed, 222 or 250, bed 1. Well, that's helpful too, but you don't have any context of what button was pushed. You don't have any context of any information about that patient. And, great if there's not like some light going off that someone has to track them down, but I still have to walk in that room and understand what I need to do. Well, the better scenario is, hey, a specific button was pushed. Maybe it was, I need ice. Maybe I'm in pain. Some of these things are much more sophisticated, or there's now screens that they can interact with. We can interpret each of those signals, transmit that signal to to the appropriate person's device, and give them clinical context. So depending on the information we're getting from the EHR, we can give additional clinical context. So as soon as that information is gleaned and glanced at on their device, they know which is the patient, they know what's their request, if there's specificity based on the buttons or device they're pushing, and we have some clinical context. So I can probably walk right in that room and have a pretty good sense of what I need to do before I have to even look at, maybe log into the EHR to figure out what's going on or look at that piece of paper I'm carrying around with me. So again, by adding context, by sending it to me when I need to know it, by filtering that we talked about in the last scenario, I'm taking away a lot of that administrative time of looking up information, of trying to figure out what's going on, of trying to figure out the urgency of why I need to go there, and giving me back some time to spend with the patient. Those seconds, that 30 seconds, those minutes add up when it happens, tens to hundreds of times over the course of a shift. Now, one of the things that I always like to point out is that there is no magic in technology. Everything I've talked about are things that we've worked with organizations to help them accomplish. But they didn't just happen by putting in technology alone. There was no magic bullet of saying, hey, turn on a switch, don't do anything else, and nothing happens. I think it's just really important to always mention that any of these process improvement projects, anything you're doing to improve physician burnout, nurse burnout, care, or the rest of the care team, involves always 3 legs of the stool. Technology is an enabler, but it's only an enabler. It's a means to an end. You have to have process and leadership to look at this and define the before and after state and how you're going to do that. And you have to have the right culture to adopt change. You have to have sort of the willingness to change the way you do things, the willingness for people to adapt to new processes or maybe to give up old things. But we've seen organizations have tremendous benefit by taking these 3 legs of the stool and looking at these workflows and improving them. So to wrap things up, we know burnout's a huge problem. It's something that physicians talk about all the time. It's, I think, the reason why a lot of people aren't going into medicine today, because they see the burdens of physicians and how hard it is to be there. We hear about nurses wanting to leave the bedside because they just can't, it's just too hard emotionally, physically. It's no fun, which is a shame because this is truly a noble profession where we are helping people in their most vulnerable time and have been educated and have the ability to truly make a difference. So all of us need to be thinking about how to make this better. And there's, again, no magic way to solve this, 1,000 different paper cuts to deal with, but take bite-sized chunks off of this. Focus on improving processes around how to connect the care team, helping people just find the people they need to talk to so they're not wasting that time of tracking people down. Simple but incredibly helpful. How do you save steps? Take away some of these burdensome processes where people are doing things that are not at the top of their license. Helping gain focus, making sure that there's awareness of critical patient changes and making sure they're acted on in the right way. Delegating non-clinical tasks. When things don't have to be done by a physician or nurse, they could be done by somebody else. Find ways to shift it down without any intermediaries to even have to delegate that. And finally, what we all want to do, give time back at the bedside. Looking for ways to make information actionable, taking away some of those micro sort of transactions that people have to do anytime an event happens, so they can see the information, they have context, they can assimilate it, they know the urgency, and they can act on it right away without any further information gathering. So, I hope that all of you leave today and think about, you're all, I think most of you are probably working at health systems on the call. I imagine all of you work in a number of different departments, but also everything you do, there is, I'm sure, at least one thing you've heard today, whether or not you do it with Spok, you can think about and act on to help your care teams work better. Help, again, even if you feel like that this little thing is only going to save a couple minutes here and there, the volume that you work on, the number of physicians and nurses at your institution, the number of patients that flow through the door, those seconds and minutes absolutely add up. So I hope you find a physician or a nurse and ask them how you can help. Think about what you can do to make their lives a little bit better. So thank you, and we have time for some questions.
Excellent. Thank you so much, Andrew and Nate, for that insightful presentation. We'll take some time now to answer audience questions, and it looks like we have had a few that were submitted already. If you do have a question, please submit it in the questions box in your toolbar, and then we'll answer as many as time allows. So Andrew, our first attendee question is, you show texting as a solution to contact other clinicians. What about PHI and HIPAA? Do you have a recommendation for what type of technology would be good?
Sure. Yeah, so despite best efforts at many organizations, people use iMessage, WhatsApp, whatever's on their Google phone, and stuff is being sent all over the place. There was a story, we worked with one of our customers in their pre-state before our technology. He was describing this scenario where he's a surgeon, and he often dealt with wound infections. And he worked in an area in Colorado where there's a number of remote clinics, and he'd often get calls from the emergency room saying, hey, I've got a patient who's come in with a wound infection, and for him, a picture's worth 1,000 words. But because they didn't have a way to address that question, the PHI, their workaround was they would ask the patient to take a picture of their own wound with their own phone and send it to them. Now, clearly not an ideal scenario at all. Another really quick funny story, I was talking to a vascular surgeon at another place who took a lot of pictures on his phone that were all PHI. He said, gosh, I wish I had a better way to do this because my family hates this because our screensaver on our Apple TV keeps showing the pictures of all these wounds. So I don't think anybody wants to solve it that way. And so the answer to the question is that there are technologies out there that do secure messaging. So they function and look a lot like iMessage, WhatsApp, all those other tools, but they have a couple key differences. First and foremost, they're healthcare grade security. So they've been built and have security features around them to ensure there's no leakage of PHI. They're highly encrypted. There's processes and technologies around it that make sure that PHI remains contained in the health system. It doesn't escape anywhere that's outside of the domain that they want it to escape. But the second part, though, that makes these tools useful is not just that they're secure messaging technology, because honestly, that's not that hard to do. What is harder to do is making it easy for the providers so they don't have to, for example, build their own directory. They don't have to figure out who's on call. I've talked to a number of institutions that have implemented non-Spok secure technologies, and they get stuck at 10 to 15% adoption. And I start probing of why is that? And one of the answers they give is, well, they all get this blank device, and we tell them to use it, and they have to build up their own directory. They have to put in other people's contact information, and then they can't, and they still doesn't help at all with on-call. And, so they try it because it was easy. It said, talked about people, process, and technology. Well, they just did the technology part and skipped the process and culture part, and it fails. So from a technology perspective, securing PHI, there's well-established ways to do that, but that shouldn't be your goal. If that's really your goal, you'll likely fail. Your goal should be to use these technologies to improve the provider's workflow, to make their lives easier and, make it so their directory's there, so they have their on-call schedule. And as a byproduct of making their life easier, you have also secured it in a way that lowers the risk to the organization of PHI escaping.
Excellent, thank you. Another attendee has asked about the EHR. Can hospitals leverage the investment that they already made in their EHR to improve workflows?
Yeah, so I think that's a really interesting area to improve, again, provider satisfaction. I was at one of our customers, and that was during the implementation process, so it wasn't live yet. And it was about 4:30 in the afternoon, and he was an OBGYN, and he logged into, he'd been, because of his day, he has to be in the hospital all day. But he'd been sitting around a couple hours. There wasn't much for him to do, no babies being delivered, no consults. And the way their organization did consults was you order it, and it creates an in-basket message, and this was an Epic. And the providers were expected to look at their in-basket periodically for consults. Well, we're sitting with him, and he pulls up Epic, and he sees that there was a consult that was placed for him like 2 hours ago. He's like, gosh, this is so frustrating for me. I've been sitting around doing nothing. This consult's been here. And, now he's going to have to stay later than he had to, then when the shift ended, to finish up this consult. So, frustration. But let's think about how you can leverage and use your EHR to make this process better. Well, when that consult order was placed, that EHR creates what I think of as a signal that an event has happened and someone needs to do something about that. So in this case, an order has been placed, but these signals could be all kinds of things. They could be an ADT transaction. They could be different kinds of orders. They could be clinical alerts like the sepsis alert, but those are signals. So what other organizations that we work with has done is someone puts the order in, and as soon as that order goes in, we send a message, or a message is sent from that EHR to our communication platform, and that consulting physician gets a message immediately. So instead of that scenario that I described where the provider, is frustrated because a consult's been sitting there for 2 hours, the moment that enter button is pressed by the consulting physician, by the ordering physician, that provider who needs to follow up on the consult gets a message to follow up on it. So again, it's another little paper cut you've taken out of their day. Instead of being home and maybe missing part of their dinner with their family because they got a late consult that they should have known about a few hours ago, they're done. They're home with their family. They're happier. So I think there's a lot of opportunities to look at how do you get that information to the right person immediately so they can act on it.
Excellent, thank you. Looks like we've got time for just about one more question. You talked about adoption. Have you seen any organizations using best practices to get doctors and nurses to adopt new technology?
Yeah, so there's a whole slew of best practices that go into adopting new technology. And first, I'd like to think a lot of these things are things that have nothing to do with the physician per se, but have a lot to do with the physicians or nurses being successful. Things like making sure the right policies and procedures are in place, making sure you've talked with the unions if you're a unionized hospital, making sure you have a good wireless infrastructure so they have a good experience on their phone, making sure the providers and nurses understand sort of the trade-offs that come with by using a consumer device like an iPhone and an Android phone. A lot of advantages, but some things, some things that are harder to control. Like, for example, if you put yourself on Do Not Disturb on an iPhone, it's not going to beep. So, and you won't hear the beep like you would a pager, and that's just the way the iPhones work.
So Paige, I wanted to add something to that point also, Dr. Mellon, around adoption. There are two things that I found that our customers are doing that work as well. One is including, to your point around culture and process, include your clinicians up front. Include your nurses, include your doctors as you select your technology, as you bring demos in, as you make purchasing decisions. Even if, a lot of times the clinicians don't have time and they're very busy, but we found that including them early on in a decision in the process is very valuable. They will feel like they have a stake in it. The other piece is around understanding their workflows. And again, I think Dr. Mellon talked about this as well in terms of process. A lot of times I see our customers sometimes get technology for the sake of technology, right? There's a group of clinicians that have a complaint, and so therefore let's fix that with technology. And the issue on the back end is that a thorough workflow analysis, a before, right, a current state, a future state, and an ideal state analysis should be done up front so you can understand the clinician's workflow and ensure that you're getting the right technology to help them solve any problems or be more efficient. Most of the technology we see in the market today, we purchase and we just kind of put into the the clinical workspace, and we find nurses and doctors adopting their workflow to the technology. And so I urge us to look at it differently and say, here is our workflow. Here's how we do things, and here's maybe where we need to change some things, and how can we best align that with the technology.
Yeah, well said, Natay. I would say the #1 best practice is only put in technology to solve a goal that improves the clinician's life and workflow. With that as your #1 goal, and everything else should be supporting that.
Amen.
Excellent. Thank you both, and thank you to our attendees. Unfortunately, we are out of time, so we will conclude there for today. If we were unable to get to your question today, we will be sure to follow up with you offline. And if you'd like to chat with a Spok representative on the topics that we discussed today, you can do so using the link that is in your chat box. You can also continue the conversation with fellow attendees by using the hashtag #SpokWebinar on Twitter, and follow us on Twitter, LinkedIn, and Facebook to get all of the latest news from Spok, as well as industry news and trends. Thank you all again for joining us. We hope that you found this webinar informative, and you have a great day.